Hello, this is David Bishai, and this is our lecture on market power in health systems. So let's talk about who has power and why they have power. Insurers have power when they accumulate a large number of insured individuals. Remember, they do need to be large to be at the proper scale. They need to have 10,000 or more lives covered in order to achieve the law of large numbers. But using that power, they can negotiate down fees. They can force more capitated contracts. They can force risk outside of their own ledgers and onto the budgets of the providers. The hospitals need to be large. The larger the hospital, the more volume it has. Their surgeons can be smarter about liver transplantations if they do hundreds of liver transplantations. The more the teams do various procedures, the better they are. And so small, tiny hospitals don't have that advantage. They don't have the ability to specialize so much. But the final thing we're realizing is that hospitals need to be large in order to bargain back against those large insurers. So a small one-off hospital is going to get crushed in trying to bargain back against a large insurance chain with hundreds of thousands of lives. Now, we've been using the word concentration in this lecture. The word concentration means very few firms, and high concentration means very low competition. So we measure concentration as an index of monopoly. You'll see in the readings and in your studies of health economics an index called the HHI, or Herfindahl-Hirschman Index. And the way you calculate an HHI is you count up the market shares of your firms, and then you take the sum of the squared market shares. So the HHI is the sum of the squared market shares of all the firms in an industry. Supposing we had a monopoly with one firm having 100% of the market, its HHI is 100 to the second power, which is 10,000. If we had a duopoly, it would have an HHI of 50 squared plus 50 squared, or 5,000. If we had 100 hospitals with 1% of the market each, we would have 1 squared plus 1 squared plus 1 squared up to 100, which would be 100. The Department of Justice uses the HHI, and it says we're not going to allow mergers in an industry that has an HHI of more than 1,800. So somewhere, if you can look at a duopoly of about HHI of 5,000. Disallowing mergers happens in firms where there's 5 or 6 or 7 different firms in an industry. At that point, concentration is low enough for the Department of Justice to leave it alone. Fewer firms than that, mergers are not going to be allowed. Managed care absolutely changed the nature of hospital competition. We saw in the graph that prior to the 1990s, there was low concentration, there was wasteful quality competition. Insurance wasn't forcing price reductions. They were not coming in and hammering those reductions. Hospitals would compete on the basis of how beautiful they were, beautiful sculpture gardens and wood paneling. There was a medical arms race to just buy capital, but not to negotiate price discounts. But you saw in our graph that after the 1990s, in the era of the MCO, the hospitals were pounded by large insurance chains that led to price concessions. And the MCOs succeed more where there are many, many hospitals that have been divided up, and so it can pick them off one by one using the monopsony buying power. As a way to fight back, the managed care era saw lots of hospital mergers. Hospital markets with low concentration consolidated, hospitals formed chains in order to push back against the monopsony providers, payers that were trying to bring down their price. So what we see now are not fully monopsony, but oligopoly hospital chains selling beds to oligopsony MCOs. Oligo means not one, but few hospitals selling to few managed care companies or insurance chains. The managed care side is the buyer. They are buyers of beds who resell the beds to the patients, and if they buy cheaper beds, they make more money. So let's just quickly give the buyers here a theory of monopsony so we can cover them. we saw the theory of monopoly in part 1 of this lecture. Monopsony theory is just a monopoly upside down. We have a demand curve, one demand curve, but the monopsony buyer knows that since they're the only buyer, the more they buy, the higher the price goes. So they want to restrict their demand, and when they restrict their demand, they can get a lower price. So even though the industry supply is this big curve, the marginal cost to that one buyer is on their own curve, which is just a little bit above the industry supply line. So how do you act like a monopsonist? You try to get your marginal cost to equal your marginal benefit on this demand curve. So this is your marginal benefit on the demand curve. This is your marginal cost on the marginal cost curve. Monopsonist says, I want to restrict my quantity demanded to quantity MS here. And what price will I want to offer the supplier? I won't offer the price way up here. No, I'm going to offer, look at the industry supply curve, and now I can offer price of the monopsonist, P sub MS, and I will get a price reduction below P star, which is great for me. I'm a buyer. The lower my prices, the better off I am. What we see again is a deadweight loss to society. These are resources whose marginal benefit is greater than marginal cost, but they're not produced because the monopsonist doesn't demand them to be produced. They are restricting their supply away from the social optimum, and we have a deadweight loss. Now, analogous to the windfall profit of the monopolist, there is a windfall savings in yellow here. The monopsonist has marginal benefit line up here at their marginal benefit line, but they have negotiated a price reduction P sub MS, so they get all this benefit, but they only pay P sub MS. This is money in their pocket, and they're really happy to take that money. So now we are drawing them both together. What I've drawn here are a monopoly hospital and a monopsony insurer meeting each other. We have the hospital supply of beds going up. We have the insurer's demand for beds going down. We have the marginal revenue curve the monopoly hospital sees. And we have the marginal cost curve of the monopsony buyer above the hospital supply of beds. So now they both try to do their thing. The monopsonist says, I want to restrict my quantity demanded to QMS. The monopolist says, I want to restrict my quantity supplied to QMP. They're kind of close together on their quantity demanded and supplied. They might both agree. But now the monopolist says, I want to charge high price of the monopolist way up here. And monopsonist says, I want to pay price of the monopsonist way down here. So they might agree on quantity supplied and demanded, but they definitely don't agree on the price. And they're worlds apart, unlike where we were with the perfect equilibrium over here at PC. They end up actually in this yellow triangle that we'll call the contract curve. The contract curve is the set of possible equally beneficial outcomes where we might find this equilibrium. We might find them at perfect competition. That is like a none for you and none for me equilibrium. They both get no windfall profit whatsoever. Down here, if they pay the price of the monopsonist, the monopsonist gets everything. All of the windfall and the revenue goes to the monopsonist. If they end up over here at the monopolist's favorite spot, they pay the price of the monopolist, they have the quantity supplied of the monopolist, and the monopolist gets everything. What do you do? How do we solve a game like this in game theory? Now, economic theory doesn't have a clear prediction. They end up inside that core of the market. We can call that core an Edgeworth box. If you want to recall what you know about Edgeworth boxes, I'll be talking more about Edgeworth boxes later in the course. But they come to a bargaining table and they do bluster and bravado to get the best deal they can. So there's a couple of predictions that we do have, even though we can't say this is exactly what the quantity and the price will be, we know that society is going to lose, that the quantity is not likely to be out at peace at quantity star. We're going to have some restriction of quantity away from the market optimum, and we're going to lose some units whose cost is less than their marginal benefit. The price is somewhere in between the high price of the monopolist and the low price of the monopsonist. If we track concentration on one end of the bargain and we try to tell the monopolist, no, you terrible hospital chains, you're charging too much, we might not make it better because we have monopsonists also ganging up on the hospitals. So this is a theory that sort of tells us what we saw on that chart where the Medicaid and Medicare bargainers say we are monopsony buyers and we are definitely going to get a price reduction. And the hospital is saying we are monopoly sellers and having power over the private providers in order to get those windfall ratios of price to cost. So our theory says that bargaining matters a lot, power dynamics matter a lot, but what makes it even more complicated is that even though I'm giving you theories of one monopolist, one monopsonist, we have this oligopsony buyers, several or so private payers, Medicare and Medicaid all competing, and we have hospital chains fighting back. So it's chess in three dimensions. The theory I've given you is a start to understand that there are definitely losers of society having quantity restrictions, but there's a lot of leeway for bargaining to change the final price in the system. And so what we'll expect to see is a lot of variability in what the system will be at over time. We'll see sometimes private providers paying a lot, sometimes paying less, sometimes Medicare paying a lot, sometimes paying less. So let's stop there and we'll come back and think more about the behaviors of hospitals in this system.